hypertonic and hypotonic conditions كمدخل للحديث عن the sodium, which is the most abundant extracellular cation. Osmotic activity means concentration. وعشان أحسب osmotic activity a solution solute ده بجمع كل different salt particles in that solution، وناخد بالنا إن المونوفالنت ions زي مثلا الصوديوم اللي هو carry one charge. This is the monovalent carry one charge. فإن الملي equivalent بيكون هو نفسه الملي مور بير لتر. ناخد مثال كده الأزوتونيك سلاين اللي هو صوديوم كلورايد أو نورمال سلاين 0.9% صوديوم كلورايد، ده contain صوديوم وcontain كلورايد، يبقى هنضيف the osmotic activity or the concentration والصوديوم اهو plus the chloride. كل واحد فيهم يساوي 154 أو 154 ملي equivalent أو ملي مول بير لتر. هيبقى النتيجة النهائية الأوسموتيك اكتيفيتي of the isotonic saline 308 ملي أوسمول بير لتر. في تو تيرمز معروفين، الأوسمولاريتي والأوسمولاريتي. الأوسمولاريتي كما شايفين حرف الآر هو مختلف عن ال الثانية. هو الأوسموتيك اكتيفيتي per volume of the solution which include the solutes plus the water and is expressed as millismol per liter. بينما الأوسمولاريتي is the osmotic activity per volume of water, we mean the solvent itself, which is expressed as milliosmol per kilogram of water. Although both are technically different, but they are functionally the same, and both terms can be used to describe the osmotic activity in body fluids. The term tonicity or effective osmolality. It is the relative osmotic activity in two solutions separated by a membrane that allows the passage of water, not solutes. Water passes from solution with lower osmotic activity and is called hypotonic solution to the solution with higher osmotic activity is termed hypertonic solution. If this separating membrane is permeable to water and solutes, the added solute will equilibrate fully across the membrane with no movement of water between the two compartments. An example of this is urea. So, in azotemia, organ failure, in which there is increase in blood urea nitrogen, it is a hyperosmotic but not a hypertonic state. Plasma osmolality can be either measured by the freezing point of depression method or calculated by the following equation: 2 times plasma sodium plus glucose plus blood urea nitrogen. We use 2 times the plasma sodium to account for the chloride, which is a negative charged ion and is linked to the sodium, and is nearly the same concentration which is 140 millimole per liter. Then the blood glucose is 90 milligram per deciliter, divided by 1/10 the molecular weight of glucose, which is 18, زائد the blood urine nitrogen, which is 14, divided by 1/10 the molecular weight of blood urine nitrogen, which is 2.8. Now, the question is why we divide by tenths molecular weight. ليه بنقسم على 10 المولكيولار ويت؟ ليه؟ اللي هي 18 في حالة الجلوكوز بدل 180 و 2.8 في حالة البلاد يورناج بدل 28. لذلك لأني بحول من ملي جرام بر ديسيليتر أو برسنت يعني to ملي مول بر ايه؟ بير لتر. الليتر ده 10 أضعاف الديسيليتر، يبقى الناتج هضربه في 10. بدل ما اضربه في 10 هقاسم على 10 المولكيولار ويت اللي هي 18 بدل 180 بالنسبة للجلوكوز، و 2.8 بدل 28 في حالة البلاد يورين نيتروجين. ناخد بالنا إن ال 28 بتاعة البلاد يورين نيتروجين جت منين؟ 28 دي جت لأن البلاد يورين نيتروجين فيها 2 نيتروجين، 2 نيتروجين molecules. Each nitrogen molecule has a molecular weight of 14. يبقى بضرب 2 في 14 يبقى 28 اللي هي molecular weight of urea، اللي عشرها هيبقى كام؟ 2.8. يبقى النتيجة النهائية إن البلازما osmolarity is 290 ملي أوزمول per kilogram water. The Osmer gap is defined as the difference between the measured and the calculated serum osmolarity. Normally, the measured is more than calculated by about 1/10, or by maximum 110 milliosmol per kilogram water, due to the presence of other solutes in the extracellular fluid. The Osmer gap can be used to screening for toxins in the extracellular fluid. It will differentiate between acute and chronic renal failure. In acute renal failure, the Osmer gap is less than 10, which is normal, but in chronic renal failure, it is more than 10, and this is related to the accumulation of toxins in the blood. The plasma tonicity, as we said before, tonicity is the effective osmolarity. So, urea must be eliminated because it can pass freely between extracellular and intracellular fluid, and so it will not produce an effective osmolarity regarding water passage through the symparenal membrane. So, plasma tonicity or effective osmolarity equal to times sodium plus glucose divided by 18, as we said before. So, the net result, it will be 285 milliosmol per kilogram water, and this is the plasma tonicity for effective osmolarity. We have range. Normally, it ranges between 275 up to 295 milliosmol per kilogram of water. From this equation, we notice that the plasma sodium is the principal determinant of the effective osmolality of extracellular fluid and of the relative volumes of intra and extracellular fluids. Glucose is important only in the presence of hyperglycemia. Only in hyperglycemia. نبدأ نتكلم عن الصوديوم سواء هايبرناتريميا أو هايبوناتريميا، وده موضوعنا الأساسي. نبتدي بالهايبرناتريميا. The normal sodium or serum sodium concentration is 135 to 145 milliequivalent per liter. So hyponatremia is defined as blood sodium more than 145 milliequivalent per liter. What are the causes of hypernatremia? Either due to sodium excess, which is rare, or water depletion. Third, greater water loss than sodium, we mean loss of hypotonic fluid loss. And finally, water loss into cells. نتكلم عليهم كل واحد لوحده كده على السريع. What's sodium excess? What are the causes of sodium excess? Here is high extracellular volume. This condition is uncommon. It's either due to administration of hypertonic saline or sodium bicarbonate excessively. Other conditions are hyperaldosteronism or Conn's syndrome, by the effect of mineralocorticoids, or by Cushing's syndrome. And here there is mild elevation in serum sodium. Another cause of hyponatremia is water depletion. And here we have normal total body of sodium. And this occurs due to decreased water intake, primary hypodipsia, essential hypernatremia. Second, due to diabetes insipidus, and finally in burns. Third category that cause hypernatremia is greater water loss than sodium. That's called hypotonic fluid loss. And here there is lower total body sodium. And this occurs in renal diuresis, secondary to osmotic diuresis, namely mannitol, glucose, and urea. Also, it may involve vomiting, diarrhea, sweating, or high fever, namely due to insensible loss. Because all these fluids are hypotonic in relation to the plasma. لما قلنا ان loss of hypotonic fluids may lead to hypernatremia because these fluids are hypotonic in relation to plasma. معناها ان sodium concentration in these fluids is less than the plasma, which is 145 milliequivalent per liter. احنا شايفين ان اليورين يقل من 10 milliequivalent per liter sodium concentration. The diarrhea is 40. The gastric secretions 55. sweat is 80, furosemide diuresis is 75, and finally the only secretions which are isotonic, which have sodium concentration similar to the plasma, only the pancreatic secretions and the small bowel secretions. And by the way, urine concentration of sodium varies according to the daily sodium intake. يبقى أي loss في أول fluids عدا البنكرياتيك small bowel secretions may lead to hypernatremia. ونلاحظ أن الهايبوفوليميا in hypotonic fluid loss is not so prominent as in whole blood loss. ليه؟ This is because the resultant hypertonicity draws water out of cells, helping to maintain the volume of extracellular fluid compartment, هو intravascular compartment. آخر سبب من أسباب الهايبرناتريميا is water loss into cells, as in severe exercise and seizures. Sodium rises 10 to 15 milliequivalent per liter in few minutes. The intracellular breakdown of glycogen into smaller, more active molecules as lactate can increase water uptake into cells. However, this condition returns to normal in 5 to 15 minutes after cessation of exertion. What is the clinical picture of hypernatremia? Chronic hypernatremia is tolerated, while acute hypernatremia with sodium more than 158 milliequivalent per liter will be represented clinically, clinical manifestations. They have signs and symptoms of dehydration, as thirst, nausea, tachycardia, and hypotension. May have neurological manifestations due to cellular dehydration in the form of lethargy, hyperreflexia, may proceed to seizures, coma, and finally death. Rapid decrease in brain volume can rupture cerebral veins and produce focal intracerebral or subarachnoid hemorrhage. Some patients may present with hyperthermia. Pre-renal failure may occur due to low cardiac output. The treatment of hypernatremia depends on the cause. If water excess is suspected, give diuretics and replace with hypotonic fluid. If water depletion is the cause, replace free water deficit slowly with fluids containing minimal sodium. If sodium depletion is the cause, correct hypovolemia with normal saline rapidly, then replace free water deficit slowly to prevent intracellular dehydration. For diabetes insipidus, desmopressin can be used. Now, how to calculate the total body water deficit? Total body water deficit equals the normal total body water plus current total body water. So we have to calculate current total body water. Current total body water equals normal total body water time 140 divided by the current sodium. With the use of normal saline, use the same volume. With half normal saline, use double the volume. To limit the risk of double edema, free water deficit should be replaced slowly so that sodium decreases no more than half milli equivalent per liter per hour, and this typically requires 2 to 3 days. The brain cells initially shrink in response to hypertonic extracellular fluid, but cell volume is restored within hours, and this restoration of cell volume is due to the formation of osmotically active substances called idiogenic osmoles. Once the brain cell volume is restored to normal, aggressive replacement of free water can predispose to cerebral edema and seizures. What are the acidic implications of hypernatremia? If the sodium concentration exceeds 155 mg per liter, postpone elective surgery due to the effect on intracerebral compartments. Insert the central line with cautious correction of sodium level. Yeah. What about the different sodium regulation in head injury? ممكن عندنا 3 احتمالات بالنسبة للصوديوم in head injury and some CNS insults. We have either diabetes insipidus or syndrome of inappropriate antidiuretic hormone secretion, or what's called cerebral salt wasting. In diabetes insipidus, of course, there is increased the sodium, there is hypernatremia. And this syndrome results from decrease in the release of antidiuretic hormone produced by pituitary and responsible for water reabsorption by the kidney. And hence, we get hypernatremia and large amount of urine which is free of solute, nearly water. The opposite side, in syndrome of inappropriate antidiuretic secretion in cerebral salt wasting, in these both conditions, we have hyponatremia, which means decrease in the sodium concentration in the plasma. But the mechanism differs between sciatica and cerebral salt wasting. In sciatica, we have it is inappropriate release of antidiuretic hormone, and this hormone will lead to water retention with subsequent dilutional hyponatremia. It's not the case in cerebral salt wasting. In cerebral salt wasting, there is excessive release or loss of both water and solute in the urine, and we get hyponatremia. The hypertonic syndromes, we have diabetes insipidus and non-ketotic hyperglycemia. What is diabetes insipidus? excessive loss of urine that is almost pure water, I mean it is devoid of solid, due to deficiency of anti-diuretic hormone, which is a hormone secreted by the posterior pituitary that promotes water reabsorption in the distal tubule. So we get hypernatremia. Diabetes insipidus is either central or nephrogenic. Central diabetes insipidus, usually within 24 hours of the inciting event, which is traumatic brain injury, anoxic encephalopathy, or meningitis or brain death. While nephrogenic diabetes insipidus, it may follow infection of the kidney, hypokalemia, some drugs as lithium or dimethylcycline. The effect in concentrating ability is not so severe as in central diabetes insipidus. Diagnosed diabetes insipidus, we have to dilute urine in the face of hypertonic plasma. In central diabetes insipidus, urine osmolarity is below 200 milliosmol per liter, while in nephrogenic diabetes insipidus is between 200 and 500 milliosmol per liter. Diagnosis is confirmed by noting the urinary response to fluid restriction, failure of urine osmolarity to increase more than 30 milliosmol per liter in the first few hours after complete fluid restriction. Response to 5-unit intravenous vasopressin will differentiate central and nephrogenic. Of course, in the central diabetes insipidus, urine osmolarity increase at least 50%, which is not the case in nephrogenic diabetes insipidus. Management of diabetes insipidus replace free water deficits slowly. For central diabetes insipidus, vasopressin 2 to 5 units subcutaneously every 4 to 6 hours. Serum sodium should be checked carefully using vasopressin therapy, because water intoxication and hyponatremia can occur if central diabetes insipidus begins to resolve. For non-ketotic hyperglycemia, it occurs in patients with enough endogenous insulin to prevent ketosis, precipitated by endogenous stress as infection and trauma. It may occur with or without a previous history of diabetes mellitus. Here, plasma glucose is often 1000 mg per deciliter or higher, in contrast to diabetic ketoacidosis, which is usually below 800 mg per deciliter. Persistent loss of glucose in urine can lead to profound volume loss. The clinical manifestations of non-ketotic hypoglycemic are altered mental status and may be signs of hypovolemia due to excessive urine loss by hyperglycemia. It may progress to frank coma as plasma tonicity exceeds 330 milliosmol per liter. Advanced cases of encephalopathy can be accompanied by generalized seizures and focal neurological deficits, a condition known as hypernatremic encephalopathy. Fluid management in non-ketotic hypoglycemia. Due to excessive glucose loss in the urine, you may get profound hypovolemia. So rapid correction of plasma sodium with hypotonic saline or 5% albumin is recommended. Free water deficit should be estimated and replaced slowly. Every 100 mg per deciliter increase in plasma glucose, the plasma sodium should fall 1.6 to 2 milliequivalent per liter. So the actual or corrected plasma sodium should be used. For insulin therapy, should be deferred or withheld until the vascular volume is corrected first. It is defined as decrease with plasma sodium concentration less than 135 milliequivalent per liter. There are three main causes of hyponatremia. Number one, water excess, and here there is no edema. Second, unbalanced sodium and water excess, and this includes the edematous states of the body. And finally, unbalanced sodium and water deficiency, which occur in due to hypovolemia here. Terrible hyponatremia due to water excess, but there is no edema. قسم إلى حاجتين: urine osmolarity less than 100 milliosmol per liter، في حالات excessive intravenous hypertonic fluids، drinking excess water، and the TURP syndrome. While decreased water excretion, and here urine osmolarity exceed 100 milliosmol per liter, and this follows post-operative state of stress, SIADA or syndrome of inappropriate antidiuretic hormone secretion, and decreased solute intake. The syndrome of inappropriate antidiuretic hormone secretion. Here there is the appropriate release or an osmotic release of antidiuretic hormone characterized by inappropriately concentrated urine in the face of hypotonic plasma, which is less than 250 milliosmol per kilogram water. The causes of SIADA or syndrome of inappropriate antidiuretic hormone secretion are pulmonary diseases, some neurological disorders, namely infection, tumors, subarachnoid hemorrhage, before cancer, particularly oat cell carcinoma of the lung, some drugs with oxytocin, non-steroidal anti-inflammatory, after major surgery due to pain afferents that stimulate the antidiuretic hormone release may last 2 to 5 days, symptomatic HIV virus, and may be idiopathic, the last cause. The treatment of hyponatremia due to SIADA, water restriction or asymptomatic chronic SIADA, hypertonic saline or salt tablets orally, preferably with loop diuretics for severe symptomatic or resistant hyponatremia, glycocycline or lithium, if we tried, 30 gram urea per day to enhance water excretion. However, many cases are transient and resolved with the cause. Another category of cause of hyponatremia are due to unbalanced sodium and water excess. And here there is edema. It's either due to renal failure and here the urine sodium is more than 20 milliequivalent per liter, or another category in which the urine sodium is less than 20 milliequivalent per liter. This includes liver cell failure and heart failure. Finally, hyponatremia due to unbalanced sodium and water deficiency, and this is called hypovolemic hyponatremia, either renal or extra-renal. The renal, which urine sodium is more than 220 milliequivalent per liter, it follows diuretics. Interestingly, it follows thiazide rather than loop diuretics. Renal tubular acidosis, hypoaldosteronism, and cerebral salt wasting. What may be due to extrarenal causes, where the urine sodium is less than 20, and this follows diarrhea, vomiting, and pancreatitis. نلاحظ هنا إن الهايبوفوليميك diarrhea والvomiting كانوا ذكروا في أسباب الهايبوناتريميا، لكن في الهايبوناتريميا الديارية والvomiting ما بيعملوش هايبوفوليميا، ولكن يكون اللوس of hypotonic fluids only will produce hyponatremia. But for the diarrhea and vomiting to produce hyponatremia, there must be hypovolemia. بس الأمور واضحة. Hyponatremia without hypoosmolality. It's called pseudo-hyponatremia. Usually, hyponatremia is associated with hypoosmolality. However, in some exceptions, it is not the case, and we get what's called pseudo-hyponatremia. We have either hyponatremia with normal plasma osmolality, as this, with normal plasma osmolality، ودي ممكن نشوفها في حالتين: extreme elevations in lipids and proteins, and in particular lipids is the most popular in this respect, and here the patient is asymptomatic. And the second condition is marked glycine absorption observed in TUR syndrome. The explanation of the hyponatremia in the presence of excess lipids in the circulation is technical measurement of the sodium itself. In the classic method, the sodium is measured in whole the plasma, both aqueous and non-aqueous form. And normally, the aqueous form represents 93%، يعني حوالي 93% من البلازما aqueous، وهذا الصوديوم موجود في هذا الجزء. الطريقة الكلاسيكية بتقيس صوديوم the whole plasma، والديفرنس 93% للفرق بسيط، ما بيظهرش أي تأثير. في حالة hyperlipidemia بتزود non aqueous portion of the plasma. So when we use the classic method in measurement here, we get low sodium or hyponatremia. تاني حالة ممكن عندنا hyponatremia لكن معاها increased plasma osmolality، and we get what's called hyperosmolar hyponatremia، ودي بنشوفها في حالتين: يا اما الهايبرجلايسيميا، يا اما mannitol in big doses and in renal insufficiency, because mannitol in the usual doses usually produce hypernatremia secondary to more water loss than solute. The clinical picture of hyponatremia. In mild cases, which the sodium is between 125 to 130 milliequivalent per liter, we have just GIT upsets in the form of nausea and vomiting. In more advances, we get neurological symptoms in the form of lethargy, headache, seizures, psychosis, coma. Respiratory depression and muscle weakness may also occur. The treatment of hyponatremia, we have to treat the underlying cause and cautious correction of hyponatremia. This may include fluid restriction and diuretics, microcycline or syndrome of inappropriate antidote hormone secretion, and the condition may require sodium replacement. How to replace sodium in hyponatremia? ممكن يكون orally, maybe isotonic or hypertonic saline, and calculate the sodium deficit equal normal total body water time 130 minus current plasma sodium. ونلاحظ هنا استخدام ال 130. So the aim of the correction is to reach 130 only. Intravenous sodium replacement. عشان نحسب ال IV sodium replacement نبدأ أولا بحساب total body water. This is the total body water in liters. دي تبقى 60% أو 50% according the patient is man or woman respectively. Suppose عندي lady وزنها 60 كيلو والصوديوم الحالي فيها 120 ملي ايكويفالنت بير لتر، يبقى التارجت بتاعي ان اوصل الصوديوم ل 130 واضرب 50% ده 50% في 60 كيلو جرام اللي هو وزن الليدي this lady. ال 130 صوديوم التارجت بتاعي ناقص الكرنت صوديوم ال 120 هتكون النتيجة ان عندي ديفست 300 ملي ايكويفالنت صوديوم in the body. لو هستخدم هايبرتونيك سلاين 3%، الهايبرتونيك سلاين 3% بيحتوي 513 ملي ايكويفالنت صوديوم، لأن النورمال سلاين 9 بيحتوي 154 ملي ايكويفالنت، بضرب تقريبا في 3 وتلت يديني 513 ملي ايكويفالنت صوديوم. عشان أحسب الفوليوم in liter required to correct this deficit هقسم 300 ملي ايكويفالنت صوديوم ديفست على صوديوم كونتنت الموجود في لتر من هايبرتونيك سلاين اللي هو 513 يديني 585 ملي of hypertonic saline. عشان نحسب الريت of correction فعادة بنستخدم الماكسيمم ريت نص ملي equivalent per liter per hour to avoid risky complication known as demyelinating encephalopathy. This one. يبقى عدد الساعات اللي هحتاجها 20 ساعة at least. جات من 20 ساعة أنا عندي 120 عشان توصل ل 130 يبقى عندي 10 ملي ايكويفالنت ملي مول صوديوم. لو هستخدم الريت نص ملي ايكويفالنت بير لتر بير اور يبقى ال 10 على النص هيديني 20 ساعة. يبقى الفوليوم اللي عندي اللي هو 585 اللي انا حسبته الاول على عدد 20 ساعه يبقى النت ريزلت بالنسبه لي 29 ملي per hour. طبعا لو اضطريت استخدم او حبيت استخدم ايزوتونيك سلاين وكانت الظروف تسمح، فالفوليوم اللي هستخدمه هيكون 3.3 تايم الايزوتونيك saline of course الهايبوتونيك saline. الانترفيرنس سوني ريبليسمنت لا يقف على ذلك. احيانا في سمبل ايكويشن بتستخدم بدل ما اقعد احسب وضيع وقتي في حساب هذه الايكويشن، في سمبل فورمولا اللي هي 1 ل 2 ملي لتر per kilo per hour of 3% saline. In some severe cases with seizures, I can start with 100 up to 150 milliboluses can be given, and it can be repeated as required. And in this case, it's very important to monitor the serum sodium frequently, even every 1 hour. In general, it's not recommended to increase the serum sodium by more than 6 to 12 millimole per liter in the first 24 hours and maximum 18 millimole per liter in the 48 hours. في معادلة تستخدم لحساب قد ايه الفوليوم اللي قد ايه بيغير الصوديوم اللي عندي او بيزود صوديوم قد ايه، يسمى بالتشينج ان سيرم صوديوم. المعادلة بتقول الانفيوزيت صوديوم ماينس الكارنت سيرم صوديوم على توتال بودي ووتر زائد 1. عندنا مثال 60 كيلو ميل presenting with seizures and his sodium is 110 ملي مول per لتر. لو هستخدم هايبوتونيك سلاين هيكون الانفيوزيت صوديوم بتاعه كام؟ 513 ملي مول per لتر. يبقى الانفيوزيت صوديوم اللي هو 513 زي ما قلنا قبل كده ناقص الكارنت صوديوم اللي هو 110 على توتال بودي ووتر بضرب 60 كيلو 6 من 10 زائد 1 زي في المعادلة هيديني 10 ملي مول per لتر. إذا لما أدي 1 لتر of this fluid اللي هو hypertonic saline فيه 513 ملي equivalent per لتر، أتوقع إن الصوديوم يزيد by 10 ملي مول per لتر. وطبعا زي ما قلت الكلام ده هنديه خلال few hours according to the circumstances. Hyponatremic encephalopathy. Metabolic encephalopathy due to cerebral edema, increased intracranial pressure, seizures, maybe RDS, with subsequent respiratory arrest in severe cases. And this is the clinical picture of severe hyponatremia. في نفس الوقت in a rapid correction of hyponatremia may lead to central pontine myelinolysis, pituitary damage, and oculomotor nerve palsy. إذن hyponatremia by itself can lead to encephalopathy. في نفس الوقت rapid correction may lead also to encephalopathy, a condition known as central pontine myelinolysis. The TURP syndrome, the transurethral section of the prostate, due to its vascularity, opens venous sinuses, allowing the absorption of hypotonic glycine 1.5% irrigation fluid into the systemic circulation. The volume absorbed depends on the duration of the procedure, the hydrostatic pressure of the irrigating fluid or the height of the back of the patient, and of course the vascularity of the prostate. Three classical features of TURP: dilutional hyponatremia, fluid overload, and glycine toxicity. The signs and symptoms of TURP are cardiovascular tachycardia, hypertension, followed by hypotension, angina, and cardiovascular collapse. Neurologically, we get confusion, convulsions, and coma. Treatment of transurethral section of the prostate: stop intravenous fluids and fluid restriction. Furosemide to promote diuresis, indicated mainly if pulmonary edema develops. Antiarrhythmic and vasopressors as needed. Hyponatremia causing encephalopathy may require cautious correction of plasma sodium by fluid restriction and possibly hypertonic saline. Invasive patient monitoring should be considered. Anticonvulsive therapy in measure to reduce the ICP may be instituted. And of course, cardiopulmonary resuscitation as required. السؤال: what's the difference between tonicity and osmolality؟ طبعا التونيسيتي هي الeffective osmolality، بمعنى an agent as urea should be excluded from the equation. ليه agent as urea? Because urea is not located at its site, but it passes freely intra and extracellularly, so it will not create an osmotic force regarding water traction. يبقى ده الفرق بين التونيسيتي والosmolality. What is the normal plasma tonicity؟ كلنا عارفين range من 275 إلى 295 ملي أوسمول كيلوغرام ووتر. ملي أوسمول per kilogram water. طيب, the third question is, what is the Osmer gap? Osmer gap is the difference between the measured and calculated osmolarity. Normally, the measured is maximum 10 more than calculated one. It should be less than 10. More than 10 difference is abnormal. So, if the measured exceeds calculated by more than 10 millimole per liter, so there will be toxins in the blood. For example, the commonest are alcohols. So, alcohol toxicity is a common cause of increased Osner gap. All types of alcohols, phenol, methanol, various types of alcohols. Another importance of Osner gap is to differentiate between acute and chronic renal failure. In acute renal failure, the Osmer gap is less than 10, but in chronic renal failure, it increased, and this is simply due to the accumulation of toxins in the blood. What are the causes of water depletion that produce hypernatremia؟ عندنا 3 أسباب لهذا الموضوع. الموضوع الأولاني أو الكوز الأولاني إن الواحد أصلا ما بيشربش، نمرة 1. decrease water intake. Decrease water intake is number 1. Decrease water intake. السبب ده السبب الأولاني أو ما يسمى بالبرايمري هايبوديبسيا، ودي عكس كلمة بوليديبسيا، عايز بيشرب كتير. The second cause what's called diabetes insipidus. In diabetes insipidus there is marked decreased production of anti-diuretic hormone, vasopressin, hormone secreted by the posterior pituitary, which is responsible for water reabsorption of the kidney. Diabetes insipidus طبعا this decrease in the production of this hormone. There will be marked loss of urine, which is diluted urine. يكون معانا البلازما hyperosmolar طبعا، واليورين marked diluted وhyperosmolar. Third possible cause of water depletion which produce hypernatremia is burns. حالات ايه؟ الحروق. يبقى هم دول الثلاث اسباب water depletion اللي ممكن تؤدي الى hypernatremia. What are the isotonic body fluid secretions؟ طبعا isotonic body fluid secretions اللي يكون فيها sodium concentration is nearly similar to the normal sodium in the blood, which is 1.45 millimole per liter or milli equivalent per liter. عندنا two only secretions or two secretions only which have this character. These are the pancreatic and the small intestinal secretions. Pancreatic is number 1. Number 2 is the small intestine secretions. All other secretions of the body, سواء كانت vomitus, diarrhea, diuresis, all have a marked low sodium concentration and they are termed hypotonic fluids. عشان كده عادة لما يحصل loss, vomiting or diarrhea of these hypotonic fluids which contain much less sodium in the plasma, we get what's called hypernatremia. Okay? What are the different neurological manifestations and effects of hypernatremia? طبعا ال effects or manifestations on neurology by hypernatremia are related to cerebral dehydration. العين الأول فيه شوية lethargy, hyperreflexia, and this can proceed to seizures, coma and death. تذكر برضو ان rapid decrease in brain volume may lead to rupture of cerebral veins, and this can lead to intracerebral hemorrhage or subarachnoid hemorrhage. Intracerebral hemorrhage and subarachnoid hemorrhage. تمام. السؤال الأولاني: what is the equation of current body water؟ بمعنى ان عندي hypernatremia عايز احسب current body water. current body water بيساوي total body water مضروب في ال 140 اللي هو صوديوم عادي، نورمال صوديوم يعني، مقسوم على الكرنت الصوديوم الحالي، هل هو 150 160 وخلافه. طبعا التوتال بودي ووتر دي حسبتها معروف، 50 أو 60% البودي ويت سواء كانت ميل أو فيميل. The second questions: what is the risk of rapid correction of free water deficit? طبعا the risk is cerebral edema. Hence the importance of slow correction of body fluids. Edema. The third question: what is the fluid used to correct hypovolemia and the fluid used to correct free water deficit? What is the rate of correction of each? طبعا to correct hypovolemia بستخدم النورمال saline. normal saline اللي هو 0.9%. بينما free water deficit is corrected, this free water deficit is corrected by 5% glucose أو half strength saline اللي هو 0.45%. The rate of correction for hypovolemia is rapid, a correct manifestation of hypotension, CVP وخلافه. بينما the correction of the free water deficit using 5% glucose أو half strength from saline should be slowly زي ما قلنا قبل كده to avoid the risk of cerebral edema. What are the possible sodium regulations in head injury? عندنا 3 احتمالات في الهيد انجري بشكل الصوديوم. الحالة الأولى يحصل diabetes insipidus. diabetes insipidus زي ما قلنا كده دي بيكون فيها هايبر ناتريميا، الصوديوم بيكون عالي. عندي حالتين تانيين بيكون فيهم هايبوناتريميا، يا اما syndrome of inappropriate سياد اتش anti hormone secretions، ادي واحد. الاحتمال الثالث حاجه اسمها cerebral salt wasting. تمام كده. الحالتين الثانيه والثالثه اللي هما سياده and cerebral salt wasting يكون عندي hyponatremia، increase sodium in the plasma. طب ايه الفرق بين السياد والcerebral salt wasting؟ in the سياد بيبقى فيه inappropriate production of anti-diuretic hormone، وبيكون في retention of water، يبقى عندي dilutional hyponatremia. ولكن في cerebral salt wasting يبقى في excessive loss of both water and solute. What are the causes of hyponatremia associated with body edema؟ دول طبعا سهلين معروفين. يبقى عندي يا اما heart failure، يبقى عندي renal failure، انا عندي hepatic failure. طبعا الإديمة دي ماركت. يبقى primary line of therapy هنا يكون ايه؟ الدايوريتكس. ايوه. طبعا ايه السبب هنا؟ طبعا بيبقى فيه salt and water retention، لكن الووتر retain more than the salt، يحصل لي dilutional hyponatremia. السؤال اللي بعده: how can low sodium diet affects sodium level. Low sodium diet will produce hyponatremia. What is the mechanism? The mechanism is as follows. The solute, which is the sodium, is essential for water lost by the kidney. In the presence of low sodium diet, there will be water retention, subsequent dilutional hyponatremia. عشان كده الناس بالذات في اوروبا كده بيسموهم those on toast and tea diets، ماشيين على التوست بس ما بياخدوش سولت، يبقى عندهم احتماليه الهايبوناتريميا كبيره، لان زي ما قلنا الصوديوم مهم جدا في delivery of the elimination of water through the kidney. What are the diagnostic criteria for syndrome of inappropriate anti-diuretic hormone secretion؟ يبقى عندنا هنا أول حاجة البلازما osmolality. Plasma osmolality is low. Number 1. نمرة 2 اليورين osmolality دي مهمة. اليورين osmolality أكتر من 100 ملي أسمول بير كيج، ملي أسمول بير كيج. برضه بنسبة اليورين، كان اليورين الصوديوم بيبقى عالي، صوديوم في اليورين in the urine بيبقى عالي، بيبقى أكتر من 20 ملي equivalent per liter. وبلاحظ there is no edema. يعني مش إديمتس طبعا، واحتمال يكون فيه كوز مسؤول عن السيادة، لو إن أحيانا في بعض الحالات rarely there will be it's idiopathic، لكن في أحوال أخرى كتيرة في أسباب طبعا زي ما قلنا قبل كده، سواء ستريس أو pain بتاع surgery، سواء كارسينوما مثلا certain drugs like oxytocin and others and so on. To differentiate between central and nephrogenic diabetes insipidus ده simply بشوف response to vasopressin هو الديوريتيك هرمون. طيب في ال central diabetes insipidus we get a response but not in nephrogenic. ففي central diabetes insipidus بلاقي زيادة أكثر من 50% in the urine osmolality. That's the urine osmolality بتزيد 50%. السؤال How does pulmonary disease cause SAD؟ عندنا سببين للسياد مع pulmonary disease. نمرة 1 الكانسر، lung cancer قلنا قبل كده lung ايه كانسر، سواء كان بسبب الاوت سيل كارسينوما او سمول سيل كارسينوما. تمام، دي بتدي الى ما يسمى اكتوبيك اهو lung كانسر، دي بتؤدي الى ectopic production of anti-diuretic hormone. This is the first cause. The second cause anti-diuretic هرمون. بص بقى قلم عدل. ده السبب الأولاني. This is number 1. نمرة 2 COPD. COPD COPD. دي COPD. COPD يبقى فيه effect of hypercapnia will produce renal vasoconstriction and antidiuresis. يبقى هم دول البلمونري diseases اللي ممكن تؤدي إلى syndrome of inappropriate antidiuretic hormone secretion. السؤال الثاني what are the causes of hypovolemic hyponatremia؟ دول مجموعتين، يا إما المجموعة الأولى renal causes renal، ممكن تكون extra renal extra renal. طيب الرينال يهمني ايه هنا؟ حاجتين مهمين جدا، الدايوريتكس. تمام. these diuretics ونلاحظ حاجه مهمه جدا في الدايوريتكس انه بيحصل اكتر مع الثايزايد diuretics rather than the furosemide. ثايزايد معلومه مهمه جدا، وده ليه علاقه بالسايت اوف اكشن اوف diuretics على الكدني، هل بتشتغل بيول ولا خلافه. السبب الثاني الرينال، حاجه مشهوره بتحصل هيد انجري مثلا بالسيريبرال سولت ويستنج. اوكي، دي cerebral salt wasting. السبب الثاني المجموعة الثانية في اكسترا رينال، ودي سيمبلي حالات الفوميتنج وحالات الدايريا. vomiting and diarrhea. نفرق بين الاثنين عن طريق level of sodium in the urine. في حالات الرينال بيكون اليورينري صوديوم أكثر من 20 ملي ايكويفالنت لتر، بينما في حالات الاكسترا رينال بيكون اليورينري صوديوم less than 20 ملي ايكويفالنت بير لتر. What are the causes of hyperosmolar hyponatremia? Two famous causes of such hyperosmolar hyponatremia. نمرة 1 is hyperglycemia. We have new glucose and its importance. hyperglycemia. السبب الثاني excessive dose of mannitol. يا إما mannitol يتاخد in a very big dose than usual، أو اديت mannitol في عيان في رينال ماركر رينال insufficiency. السببين دول ممكن يؤدوا لي إلى hyperosmolar hyponatremia، لأننا عارفين إن عادة الهايبوناتريميا بيكون معاها hypoosmolality. السؤال بعده clinical picture of mild hyponatremia. Here the symptoms fall on the GIT. You get just nausea and vomiting. طبعا ده يكون مع صوديوم more than 1.5 ملي equivalent per liter. قلنا عن كده نبتدي نخش في ايه؟ neurological manifestations. What is osmolality of 3% saline and can be injected in a peripheral vein and why؟ طبعا التونستي بتاعت hypotonic saline 3% is hypertonic. ممكن نحسبه من معلوماتنا عن الاوزمولاريتي او التونستي بتاعت النورمال سلاين. كلنا عارفين ان حسبنا قبل كده في البدايه النورمال سلاين التونستي بتاعته بحوالي 308 ملي اوسمول بير لتر، وده بيبقى تركيزه 9 من 10. عارفين 9 من 10% 2.9. This is the normal saline. This is the normal saline. يبقى بناء عليه 3% سلاين والهايبوتونيك سلاين اضرب تقريبا في 3 وتلت، ده يديني ان التونستي او الاوزمولاريتي بتاعت 3% سلاين تبقى حوالي 1027 ملي اوسمول بير لتر. This is the osmolality of the hypertonic saline. طبعا واضح ان ده hypertonic severely hypertonic in relation to the plasma. يبقى حوالي 285 ل 295 ملي اوسمول بير جرام بودي ويت. فبناء عليه it should be injected in a central vein rather than peripheral vein. central vein. ليه؟ لأن peripheral vein tolerate between 600 peripheral vein tolerate ما بين 600 إلى ماكسيمم 800 ملي اوسمول بير كيج. أكتر من كده peripheral vein هيحصل له إيه؟ to be damaged. What are the two possible causes of hyponatremic encephalopathy؟ طبعا عندنا هنا في الهايبوناتريميا مشكلتين. المشكلة الأولانية ممكن تحصل by the hyponatremia itself. You will get cerebral edema. It's number one. Cerebral edema. And this is due to decreased plasma tonicity or osmolality, with subsequent passage of water inside the cells, producing such edema, seizures, even respiratory arrest, ARDS. The second possible cause of hyponatremic encephalopathy is rapid correction of hyponatremia by hypertonic saline. This produces what's called central pontine myelinolysis, with subsequent pituitary damage and oculomotor nerve palsy. myelinolysis. ده السببين للhyponatremic encephalopathy, either by the hyponatremia itself, it produces cerebral edema and increase ICP and seizures. The second possible cause is the rapid correction of hyponatremia by hypertonic saline, will produce what's called central pontine myelinolysis.